This lecture is based on Chapter 43 in your McKinney book. In page 1069 of the 4th edition of McKinney has pediatric differences in the gastrointestinal system, which is just an interesting read and might help you get a little bit of a handle on some of the changes and differences that we'll see between adults and children. This is just a very broad overview of the GI system, and I kept 2 slides in as well of the child's GI system. The first issue we'll speak about is cleft lip and cleft palate. There are 3 different issues that can occur for children with this disease. They could have cleft lip, cleft palate, or a combination of cleft lip and cleft palate. Defects can occur on one side or on both sides. This group of deformities are the most common congenital craniofacial deformities. For cleft lip and palate, the incidence is 1 in 700 to 1,000 children, and 1 in 2,000 for the cleft palate alone. Cleft lip and palate is thought to be due to genetic and environmental factors like maternal smoking, but there also doesn't have to necessarily be any kind of indication like that. Cleft lip has the visible deformities, but also we could be seeing things like missing teeth, so have to add that into all of these oral surgeries that these children are going to be getting. They also might have to have dental reconstruction as well. Cleft palate can include nasal distortion, and the involvement of the cleft is variable and can be from the uvula all the way up to the hard palate, and it can have exposed nasal cavities. So this is really important as far as feeding goes for these infants, because they need to have special feeding so that we aren't getting any aspiration of the milk or formula to enter the nasopharynx. Diagnosis of cleft lip and palate could be in utero from ultrasound, but some children are not diagnosed until birth, when a gloved finger is actually put into the infant's mouth for exam. Management of these pediatric patients is usually based on the severity, but generally includes many surgeries for these kids. Motility disorders in children. GERD is not uncommon in the infant, and really we discuss GERD in the adult, and it doesn't change much as far as the pathophysiology of the disease, other than the fact that infants have a short lower esophageal sphincter, and that is what makes GERD a little bit more common in infants. As they grow, this should decrease, the symptoms should decrease, and the GERD should go away. Symptoms in infants include vomiting or spitting up after meals, hiccuping, and recurrent ear infections, and that's related to the pooled secretions in the nasopharynx. Respiratory illnesses are frequently associated with GERD, like asthma and coughing. Things that we can do to help these infants, education that we can provide parents is going to be educating that small meals are important and timing of the meals so that they're not going to be laying down, because positioning after feeding is going to be very important. We don't want them to be lying flat after they've fed. And those interventions might be all in infant needs for treatment, but also some infants are put on medications. Inflammatory and infectious disorders are really not any different between adults and children. We're not going to discuss these here. And I mention these obstructive disorders because we've already talked about intussusception and volvulus, but I think that for this course we are not going to be talking about pyloric stenosis, but I would suggest that you at least familiarize yourself with that disease before NCLEX. Malabsorptive disorders. We already talked about celiac disease, but lactose intolerance is the most common of malabsorption disorders. It's the absence or deficiency of lactase, the enzyme that breaks down lactose. And it can be congenital, but that's very rare. And that would be like the actual complete inability to make lactase. But developmental lactose intolerance is more common. Often the lactase deficiency is worsened when a child becomes ill, like has viral gastroenteritis or some sort of food poisoning. So sometimes a parent can limit lactose in the child's diet for a couple weeks and then gradually try to add things back in to see if tolerance has increased. There appears to be a little bit of an ethnic association, but if you read the ethnicities that are more apt to have lactose intolerance, it just seems like a lot. So, manifestations, diarrhea of people who have lactose intolerance is frothy, but not that fatty steatorrhea. May have abdominal distension, cramping, abdominal pain, and excessive flatulence. If symptoms get better, like I said, we can potentially try and add some things back in, but also if symptoms get better when lactose is removed, it's kind of like a presumptive diagnosis. We can have official diagnoses through breath tests as well as EGDs, taking biopsies, but if you remove lactose from a child's diet and the symptoms go away, we can presumably diagnose lactose intolerance. Dietary management is often enough, and generally we educate parents to remove lactose from their diet as well. And this is a diagram of celiac disease in the child, but we have already discussed this, so we will not go through this again.